Okay, the MRCP PACES exam is really truly an international exam. As you can see, there are a number of centers internationally that are undertaking, delivering, and conducting the exam. Obviously, it came to a halt over the period of the pandemic, and things have actually caught up. Okay, since the borders have opened, where there has been a huge backlog of candidates waiting to sit for the PACES clinical exam, particularly here in Malaysia. Okay, so as you all know, part 1, part 2, the written exam is now available, remote online, and all UK and some international candidates are using this system. So for part 1, part 2, the written component, you can actually sit for the exam online. Pencil and paper exam are still available internationally, but it's now being phased out. UK during the pandemic, okay, actually adopted the visual station 2 and 4 for PACES with a reduction of real patients. And as you may recall, station 2 is history taking, station 4 is communication and ethics. And obviously, okay, those who were sitting for the exam during that period of time all have to be fully vaccinated, and the regulation still holds in this place. So there were nearly 4,000 places offered in the United Kingdom during 2022 when the lockdown was lifted, okay, restrictions were lifted. The normal format restarted during the second diet of the 2022, and some places, okay, in United Kingdom as well as internationally were made available during the third diet. We actually here in NewMed conducted the last diet, okay, in 2022 here on site, okay, it's one of the examination center. So far, 3,000, nearly 3,000 cases has been offered internationally in 2022, largely really back to normality, but we realize there is quite a huge backlog, okay, of candidates waiting to sit for the exam. Then there have been 5 new centers that's been opened in the last 12 months. Right. So what has happened? Okay, and all of you must be so eager. So those of you who are sitting for the exam this time round, either this diet or the July diet or the last diet of the year in 2023, is that so far 13,728 candidates have been examined. The international passing rate, which includes Malaysia, is about 47.2%, whereas the UK pass rate is about 53.9%. Okay, so there are analysis done to see why has this been the case. This has been a consistent observation that has been noted, okay, in this context, particularly comparing between UK graduates and non-UK graduates. So the great majority of the single skill UK graduates that fails, they do not actually score adequate points in skill B. There are 7 skills that we examine in PACES, and this is identifying physical science, right? Whereas the non-UK graduates, they tend to fall down on not being able to achieve adequate points in skill B and C, that is communication skills, and N or E, the clinical judgment aspects. And I'll go through this in a bit more fine details later on because it's quite important. It is not relevant just to PACES candidates, it's also relevant to medical students, particularly those sitting their exam 4th and 5th year. Okay, these are all the skills that are required when you actually go before your examiners. Okay, and that's why I'm so pleased to see quite a number of medical students here physically and those that have registered to be online. Okay, what passes PACES? You don't fail a station. Okay, there are 5 stations and subsets with it. There are actually 8 encounters. You don't fail a station. What you do is that you must pass each of those 7 skills. So That's why it's quite important to bear that in mind. It's broadly very similar to our own new med final year exam MOSLA. So those of you who are sitting for your MOSLA next week, you will recognize this. Okay, you may not perform well in one of the component of the skill that you're assessing, but you don't fail that particular station. Okay, so what does it take? Okay, minimum of 130 marks. And of which of 172. But if you can see, okay, you must also pass every single skill. So if there is one skill that is actually lacking, then you actually want to make sure that you actually, thank you, Chair. You want to make sure that you actually fill in that gap, upskill yourself in that gap, in that particular aspects of the skill. So I'll go through bits by bits, okay, of the. No, I can't move the slide. Let me just see. Oh, yeah, okay. So what has been the difference between why is it non-UK graduates perform not so well in communication and clinical judgment skill? It boils down to some of the aspects of cultural and societal differences background. Okay, and I think it's quite important to bear in mind. And the college has actually done quite a fair bit of work to look into this particular aspects of the differences. Okay, that's one paper here, exploring cultural and linguistic influences on clinical communication skill. And you will note the authors here. Okay, Jen Decker is actually a previous president of the Royal College of Physicians. Andrew Elder was one of the former chief examiner for MRCP cases. So obviously, the colleges were very concerned to say, why is there a bit of a difference, okay, in the context of the various skills that non-UK graduates and UK graduates do not perform so well, okay, in that context. And I'm not going to dwell into really specific areas of this. I just want to highlight the 4 key aspects, okay, that highlighted in the terms of background, the power distance, okay, that which means that the unequal distribution of power in a society. As you know, the hospital system here in Malaysia is very hierarchical, okay, in the context, whereas in United Kingdom, you know, it's very, very equal in the context that you treat each other more or less at equal ranking in terms of interaction, okay? Uncertainty avoidance. Members of the society attempting to cope with anxiety by minimizing uncertainty. We are all not so good coping with uncertainty, okay? But some of us are better, some of us are not so good, okay, in the context. And as doctors, we need to be able to learn to cope with uncertainty, okay, in that context. Individualism and collectivism. Okay, in the context that people in society are integrated into groups, and i.e., individualism, asking for your own personal opinion, sometimes is quite difficult. Okay, for my own teaching, new med students, our own students asking for their personal opinion, sometimes you have to extract it quite hard out from them. Okay, whereas in the United Kingdom, okay, the candidates, they are much more forward-looking. They are actually much more wider in the prospect, a bit more streetwise, okay, a bit much more globally aware of what's happening in the parts of the world. Okay, so that obviously has to contribute to some of the aspects. You know, like for example, okay, respecting patients' autonomy. Okay, it's one of the key aspects of practicing clinical medicine. Okay, I think we have got no doubt, okay, of those who are here. And masculinity and femininity. There are society, unfortunately, okay, in the context, particularly those in parts of the world where men are considered to be the leaders rather than females, okay, and that does have got an influence in how people think and interact, okay, with each other. So yeah, there are lots of such differences. So just remind, and those medical students who are aspiring to become internal physician, you want to see how cases are going to be conducted when it's time for you to sit for your exam. There are essentially, at this current format, 5 stations. Okay, station 1 is respiratory, abdomen, 10 minutes each. And there is an interval of 5 minutes when you change from one station to another. Station 2, history taking, 20 minutes. Station 3, cardiovascular, neurological. Station 4, communication skill and ethics. And station 5, the big, what they call the big beast, okay, where a lot of candidates really finds it very challenging. It is what we call the BCC, the brief clinical consultation, of where they encounter 2 patients of 10 minutes each. Okay, in the context, it's a bit more like a real time where you're operating in an acute medical unit. Okay, in that context. So 7 clinical skills you have been examined on. Different numbers and combination of skills assessed at different encounters, and we have got a 3-point marking scale, and we usually do not have an overall judgment mark required. Therefore, you don't fail the station, if you see what I mean. Okay, you fail a skill. Okay, they don't give a general assessment of that particular encounter that you have. Okay, so. Okay, I'll go through this one by one. I'm just showing you this a summary slide, so don't worry. Okay, in the context that it looks a bit busy. Okay, physical examination, identifying physical signs, clinical communication, differential diagnosis, clinical judgment, managing patient concerns, managing patient welfare. So all of you look at it. It's very similar to our Mosler final year and 4th year exam, right? In UMac. Yes. Because our Mosler exam is actually an adaptation from the PACES exam. Okay, so those of you who have taken time off, I know you're a good exam next week and the week after, it's very fortunate here for you to sit here and focus. This is what I've been examining on. I can actually brush up some of these key aspects. Okay, right. So you can see for the respiratory and abdomen station, okay, 5 skills are being assessed. 2, 3, and station 4 is only just 4 skills, and station 5 are all 7 skills. So that's the one that carries the most numerical marks, okay, in that context for the current format of the PACES exam. This will be relevant for the upcoming one in March. It will be relevant in the next diet, which will be in July. In the September diet, in the 3rd diet of 2023, it will be the new format, which I will highlight on, okay, towards the end of my talk. So here you are. What are the numerical marking system? Okay, in the context that for respiratory is 20 marks. Can you see all the 5 sessions here? For the communication aspects is 16 marks. Okay, and you can see which are the various skills that is assessed in each respective station. The brief consultation is the one that always carries, okay, and most challenging aspects because it carries the maximum of 56 marks. So the physical examination skill, you must be able to demonstrate a correct, thorough, systemic, appropriate, fluent, and professional technique of physical examination. This is not an examination for identifying physical sign. You must be fluent, okay? And that's what, when I teach the final years as well, particularly 4th years, is how you examine your patient. Fluent. You mustn't appear chaotic. You mustn't appear what in our local Malaysian kalang kabut, okay? In the context that, oh, I'm not sure what I'm going to do. You must appear fluent that you are doing this day in, day out. Very fluent in your CVS, respiratory, CNS examination. The CNS examination is obviously the challenging. If you jump from all your various cranial nerves, then you are going to be really, really at risk of not scoring a lot of points. So that's the fluency, that's the physical examination. It's not the ability to identify physical signs. Okay, so if you do that, okay, you get that physical examination marking scale. Identifying physical signs is where you identify the physical signs correctly, and you don't make up physical signs, okay? In the context, you don't find physical signs that are not present. There is a lot of calibration. That's why in PACES, we got 2 examiners, okay? The 2 examiners must agree, okay, on the context of what is reasonable to achieve a satisfactory mark. For the individual may have up to about 8 physical signs, okay? Therefore, it may be not all the 8 that will insist that the candidate must elicit. It may be 6, but out of that 6, there may be 1 or 2 that is essential. Like, for example, if there is evidence of atrial fibrillation, okay, in the candidate, out of the 6 abnormal physical signs, they say that they must identify 4. Out of that 4, 1 of them must be atrial fibrillation, okay, in the context, because those are core signs, okay, in the context. So this is what called calibration benchmarking, okay. This the here in our undergraduate program, we call it benchmarking. So it is very well validated, calibrated, and we spend about up to 40 to 45 minutes between 2 examiners to decide what are agreed in terms of calibration. C, clinical communication. Be able to elicit a clinical history relevant to the patient's complaint in a systemic, thorough manner. Very focused, because you can see, okay, you don't have a lot of time, okay, in the context of fluent and professional, and you must be able to explain relevant clinical information in an accurate, clear, structured, comprehensive, fluent, and professional manner, so that you do not use medical jargon. Okay, you must use a language that the patient or the role player can understand. Okay, so that's clinical skill C. And this skill is tested in 2, 4, and 5. Okay, so it's not just one station that is being tested at this current format. Okay, in context. The new format, this skill is going to be tested in practically all the station. Okay, because now they have identified that if you look at station 2 and 4 and 5, which means that there are only limited 6 examiners are actually only in the position to do that assessment. We would like to have all the 10 examiners to be able to do that assessment. So during the pre-cycle calibration, the scenario is really very well rehearsed with the surrogate or patient to ensure consistency of responses, because each candidate must get the same experience seeing one to the other. Okay, so that the responses are not going to be different, because it poses an unfairness to the candidate, and ensure that the surrogate or patient can answer any questions that the candidate is likely to ask, okay, in the context. D, this is the one that a lot of candidates struggles with, and so is aspects of what we actually try to teach as well in medical school, differential diagnosis. Yes, it's very important to get the correct diagnosis, but you must be able to discuss and using your clinical reasoning skill to talk about sensible differential diagnosis for the patient that you have clinically assessed. So the likely diagnosis would have been agreed by the 2 examiners during the calibration, but they will also say, what would be the reasonable aspects if the candidate offer a list of differential diagnosis, and that is something during the discussion encounter that you have. And new med students would know that's what we do in the modular exam, right? And that's what a lot of you struggle with, okay, in terms of trying to think about what are the differential diagnoses. So can you see the importance of actually using that as a assessment of your clinical reasoning ability? Clinical judgment, yes. Selecting and negotiating a sensible, appropriate management for your patient, relative, or clinical setting. And also selecting appropriate investigation or treatment for a patient that you have personally assessed during the examination setting. You apply your clinical knowledge, including perhaps irrelevant knowledge of law and ethics, to the case. And this is also something that you need to think through in terms of they like you to actually practice what you actually do in real life. You don't initially first thing, I want to do a CT scan. No, you go through the logical first ranking of investigation, second ranking of investigation, focusing on what you think your differential diagnosis is. Therefore, you can either support or refute your differential diagnosis. Examiners do not like when you come out with a first and something, oh, I'd like to have a PET scan. What? Okay, what do you mean you want to have a PET scan? Where are the ordinary full blood count, UNEs, liver function test, random blood sugar, and CRP? Okay, in the context, because you can deduce so much out of the simple blood test, okay, in the context. So that's clinical judge. So E, apply clinical knowledge, relevant knowledge of law and ethics, understanding of physical science, investigation, management, and you solve your clinical problem. So F, managing patient's concern. You seek, detect, knowledge, and address the patient's or the relative concern you listen to a patient or relative, confirm the understanding of the matter at hand under discussion and showing demonstration empathy. So in session 5, this particular skill is also assessed by really we instructing examiners, the patient surrogate at least asking one question to the candidate, and the candidate should be in a position to actually respond to that particular question. Managing welfare, yeah, we're all very good, okay, in the context that otherwise most of you will not be here, and it's up to this stage, okay, the treating a patient or relative respectively, sensitively, in a manner that ensures their comfort, safety, and dignity. And that obviously, if the candidates cause significant emotional and physical discomfort and suggest a management plan that would endanger the patient's safety, usually will have an unsatisfactory marking, and a yellow card is actually usually issued, and counseling is usually recommended in that context. Okay, so as I already highlighted, okay, going through the 7 skills that I've actually illustrated in my previous slides, before the exam starts, the examiners calibrate all the cases at each station, agree on specific areas, needs to cover to award a satisfactory mark. The criteria are provided, okay, to us by the guidance, okay, also by expectation of how a competent trainee enters higher specialist training in ST3 in the UK should perform. So if you think about it, if you look at the undergraduate training and postgraduate training in United Kingdom, you do F1, F2, very similar here in Malaysia, okay, Foundation 1, Foundation 2. And usually by the end of Foundation 2, or when you enter into IMT 1, which is still like here, equivalent is MO, back there is IMT 1 or the SHO level, you should have at least now got your Part 1 MRCP. So IMT 1, IMT 2, IMT 3, Integrated Medical Training, the IMT stands for. So you are expected then to have your clinical PACES exam passed when you reach IMT 3. Because once you reach IMT 3, so that means 5 years post-graduation. So that's the standard the clinical PACES are actually set on. So if you think then in that respect, okay, therefore, you must actually have had at least 5 years of clinical experience, okay, before you actually consider trying to attempt for the clinical PACES. Yes, why you guys are so good here in Malaysia in terms of your identifying physical signs is that a lot of you are very well experienced, okay? Now, I know it, I do clinical work here, okay, in the context that you guys see a lot of wide range of diverse patients with really gross physical signs, okay? Whereas your counterparts in UK do not have that opportunity. That's why they don't do so well. Okay, they fell on that skill B, identifying physical signs. Okay, but what they're good at is they are very good at communication, addressing patients' concern. Okay, in the context. So that's the gap that you need to focus on. Okay, in actually preparing for PACES. So the passing requirements is that these 7 skills. Okay, the achievement of marks. Can you see it's not a straightforward 50%? Now, in that context, okay, because a standard setting benchmarking has already been undertaken. Okay, so if you feel that you have done badly at one station, okay, because this is examination setting, coping with uncertainty, coping with stress, coping with pressure, this is what we all have signed up to, okay, as medical doctors. You must try to remember that this will not affect your marks at the next station. So I know it's difficult, okay, in the context trying to sit down and recollect yourself. And it's the same in most of the setting as well. If you have screwed up one station, forget about it, okay, sit down and relax, okay, and think, well, I'm actually going to do better at the next station, okay, in the context. So use the 5 minutes, okay, to concentrate on the next station and not to reflect on what went before. And this applies in undergraduate examination as well. And in PACES, this is particularly difficult at station 1 and 3. where you actually have got no scenario to read because this is actually physical sign. Okay, when you go in, they say this patient presented with back pain and unsteadiness of the gait. Please examine the relevant system that you think is appropriate for the patient's presentation. So it's a CNS station. Okay, so then therefore you go in and that's your scenario. You have to go think on your feet. Okay, 6 minutes, I need to do what I think is appropriate and tell the examiners during the 4 minutes of interaction. Okay, and it's the same in the cardiovascular system. This patient has presented with breathlessness and ankle swelling with chest pain. Examine the cardiovascular system, okay, that you think has responsible for the patient presentation. Okay, so we have already decided as the examiners what are the physical signs that you should elicit because it's a pure physical examination station, and therefore you crack on and you don't talk to the patient in those physical stations. Okay. We all realize that you may be anxious and this may affect your performance. The more you practice, the easier you find it that you keep your anxiety under control. Okay, so I think it's quite important. No, medicine is yes, and the real life setting is also a very, very you work under a very stressful situation. Examination, demonstrate good technique, which I mentioned already. Okay, respiratory, abdomen, cardiovascular, neurological, in a thorough methodical manner. And 1 and 3, I mentioned that you expected to examine in no more than 6 minutes. Station 5 at this moment is like that you must be able to perform a focused examination relevant to the areas, to the scenario you have read, and the history you have obtained on the patient in front of you. So the station 5 and the current format is that you introduce yourself, okay, and there will be a scenario about what the patient has presented it, and you introduce and ask to give at least introduction in that context, and then you can talk to the patient and examine the patient at the same time. So it's a real life setting, like an acute medical assessment unit. So the new format is going to be very similar, but much shorter, okay, in that context, which I'll show you in a minute. You should start your examination at the same time as you obtain the history in station 5, okay, because as you can see at this moment, it carries a lot of marks. So why may you not pass skill A? Not examining in a systemic way, using incorrect techniques, okay, missing out significant parts of the examination. Your examination was hesitant or lacking confidence, i.e. I used to use the term kalang kabut, okay, in the context, and examining in an unprofessional manner, and yes, examining the patient through their clothing, okay? So that is actually reasons where you may have not passed skill A. So examine as many patients as possible, including those without clinical abnormalities, so that you can actually appear fluent, that you know what is the next step, okay, that you do. Have your examination technique for the various system observed by either your clinical supervisor or someone who has done the exam, okay, in the context, or by more senior colleagues that can give you a feedback, okay. I'm very, very pleased, okay, that there is actually within a hospital setting, there is a PACES group where all the trainees group together to actually look at cases and to see each other and make critique comments, okay, in the context. And obviously use a timer to practice to make sure how long you have to perform each aspect of the examination. Time is quite essential, okay, for you to actually making sure you actually perform optimally in that context. Able to identify clinical signs that are present. You must not report clinical signs that are not present, okay, because you really will not create a good impression. And be able to present the signs in a logical, clear manner during the discussion, the 6 minutes. So using those physical signs, you think what likely is your diagnosis, what likely is not the diagnosis because that physical sign is present, is one of the most important skills of a physician, okay, and even in the relatively easy access to investigation, okay, because this is what going to determine what you're going to request for the investigation. Confidence in this skill comes with practice, okay, practice. So A reason that you have not passed skill B is not identifying the physical signs that are agreed before the examiners, and then finding physical signs that are not present. Okay, examine as many as possible. Okay, again, reporting physical signs, reporting and discussing it with your clinical advisor, observing and asking colleagues from a different range of specialties to observe you examining patients with their consent and discuss your examination technique and examination findings with them, okay, in the context. And yes, that's quite important in terms of practicing, okay, for your ability to actually elicit physical signs. Clinical communication are examined in a variety of ways, depending on the particular station that is you are encountering. Being able to communicate clearly, essential to get acute history so that understanding medical and personal social issues can be addressed. The key to that skill is patient safety. Okay, it's patient safety. So we actually, some of you may have been to our recent CME, where we have got a drama teacher that came to demonstrate some of the games that you should be thinking that you could develop your communication skills. So the verbal skills, like questioning style, you don't want to be like an interrogating officer telling you, do you have this? Do you have that? So that means that you're not opening the question, okay, in the context, okay, you must open the question, chunking and checking, summarizing, use of silence. And can I emphasize, okay, because a lot of the graduates doing papers has forgotten about ideas, concern, and expectation, okay? This is so important, okay, in each of the respective station that contains communication, because, and can I also emphasize that once you have get their concern, ideas, and expectation, don't leave it hanging in the air, okay? Address those concerns, okay? Because that's one of the marking of the skill. It's the same in our final year Mosler examination as well, okay? My heart always breaks, okay, when the candidate have asked about the concerns but have not addressed it, okay, in the context, because therefore you don't get your full marks, okay, in the context. Facilitatory expression and signpost. The non-verbal sign cues are obviously the sitting arrangement, the eye contact that you actually have an eye contact, facilitatory gestures, and the postures. So exploring the patient's perspective, ideas. What does the patient think the problem is? An occasion, the role player or the patient may be instructed, okay, not to actually tell you what they think it is until you ask that question. Okay, that patient may have got a serious illness that carries with it a confidential element to it, like HIV. Okay, doctor, I think could it be relating to my HIV diagnosis? Okay, in the context, and that may be the first time the patient has reviewed, okay, the underlying diagnosis, because it's in a very focused setting that you're examining. So what does the patient think? What does the patient fear the problem is? Okay. What is the patient expecting? Do not obviously promise anything. Okay, you need to show your ability and recognizing to what step that you can see. So if there are issues that you don't think it's your role to be able to address, then you ask and tell the patient, I will discuss it with my consultant. I will discuss it with my lead, or I'll discuss it with my expert, okay, in that context. But at least you have responded to the patient's, okay, expectation. Has the impact of the illness affected his work, her work, hobbies, leisure activities, mobility, activities of daily living? Ask the patient what matters to you, okay, in this context. What matters to you, okay, in the context of is essentially assessing what is actually her or her ranking of her problems, okay? So especially eyes, assessing the patient understanding. When you feel unwell, what were your thoughts about your illness? What did you think? What were your main concerns? I'm interested in your thoughts in about what might be helpful before I make suggestion. Okay, so therefore you're actually throwing it back from the patient's perspective and telling you what you think you should be addressing instead of telling them what to do. Okay, so those of you, okay, in the context, this is particularly relevant for our final year students who may be sitting for the situational judgment test, the HJT. The HJT is a real test of you actually being able to approach, okay, such issues in that context. So setting the scene, you're introducing yourself, you check special age for occupation. Are you working at the moment? I understand you come today to receive some results. I understand you come today to discuss some concerns, okay. Like a real life setting, okay, in the clinic, discuss what has happened since last seen, okay, the context. This is in the history of communication ethics setting. Summarize where things have got to date. Calibrate what the patient is thinking of feeling. Negotiate the agenda. So allow the patient to complete the opening sentence, open-ended questions, avoid medical jargon, leading questions. Okay, be sensitive to the patient, read the nonverbal signs, right? Face body language, silence, tears, as well as what is said. Okay, there are some role players who are extremely good in shedding tears, okay, in the context, so you must respect them. So, no, stop for a few seconds, don't simply rush, okay, in the context that's a demonstrating of empathy, okay, in the context. Yes, I can see that you are anxious about this. I am really sorry to hear what has happened, particularly if they brought up the issue of a recent bereavement, okay, in the context. So checking understanding, what do you know about your condition? What have you been told so far? What does that news leave you feeling? I'm sorry that was difficult for you. So seeking emotional impact and acknowledge emotional content, response to the patient's feeling and predicament with acceptance, empathy, and concern. You check an understanding. Would you like to run through what you're going to tell your wife tonight when you go back home? Okay, that is such an important question, okay, in terms of what they are actually understood, what they've actually gone through and what you've gone through with them. Warning shots, right? Oh, you got cancer, you're going to die. No, you don't do that. Okay, I'm sorry, it looks more serious than we have hope. So then stop for a few seconds, okay, let them recollect, and then they may respond to you, doctor, what do you think it is? Then you can actually start off, okay, in that context. That's the sort of interaction. Basic information, simple, honesty, appropriate language, chunk and check, and allow the patient to ask questions. Offer specific help by breaking down overwhelming feelings into management concerns, prioritizing and distinguishing the fixable from the unfixable. Okay, so there are some things you got to admit you can't fix. So therefore, you need to be able to demonstrate what you can actually do, okay, in the context. Identifying a plan of what is going to happen next, offer support to the patient, offer early follow-up appointments, offer to speak to the spouse or partner, identify support systems, offer written information, and thank the patient for coming, okay, particularly in those communication and history-taking stations. Alcohol and smoking, okay, if it is relevant to that particular station, okay, particularly for station 2 and 4, must be asked. Do not assume anything, must be quantified. Beware of the ex-smoker and the ex-drinker. Difficult areas, okay, difficult areas, these are the 6, okay. Rare conditions, yes. Malaysian doctors, Malaysian students don't see much of hemophilia, okay, in the context. They don't see much of multiple sclerosis, okay, unless you are in the specialist hospital unit, okay, in the context. But those are relatively run-of-the-mill aspects that one encounter in the United Kingdom. Breaking bad news, end-of-life decisions, sensitive subject, complaints, and medical errors. These are the difficult areas that you need to acquaint yourself to. So that is a skill that continuously being developed through your clinical practice and your encounter, okay? Seeing patients and building up that skill. Session 2, able to take a systemic and thorough history, identifying patients' concern, a great management way in no more than 40 minutes, Session 4, relevant clinical information, accurate, clear, and structured manner, structured interview, but yet flexible enough to respond to questions and concerns of the patient or surrogate. You should really spend a full 5 minutes reading the scenario to ensure you are very clear about the task. So very important. What are you expecting to do, okay, during that 5 minutes of reading that you've been asked to do? And remember, it's taking a focus history based on the scenario you have been given. It is not the full history in session 5, okay? So not explaining the relevant clinical information in the accurate and clear fashion, okay, in the context, missing out information, giving inaccurate and unclear information, okay, which is really crucial for passing skill C, using information that includes too much specialist language that the patient did not understand or was unprofessional. So avoid those medical jargon. Differential diagnosis is a linked skill. This means that if you fail to identify the physical sign, skill B, you will be marked down on differential diagnosis. You must include the correct diagnosis and take the appropriate differential diagnosis for the patient in front of you. Go for the obvious one, the top diagnosis followed by your differential diagnosis. A good differential diagnosis for the wrong signs will not be regarded as unsatisfactory. So, linked skills marking, assessing candidates on the approach to the solution posed by the specific case. Good differential diagnosis of the wrong sign should not be regarded as satisfactory. Good management of the wrong condition should not be regarded as unsatisfactory as well. So we as the examiners must try to bring back candidates back to the correct diagnosis if they're on the right lines, but usually at the most a borderline should be given for skill D and E if skill B has been marked unsatisfactory. So that's what called linked skill marking if you have got the diagnosis wrong. Okay, so reflect on when you're actually practicing, okay, on what you have been performing. Practice information gathering, information giving as often as possible. You sometimes want to ask your patients that you see for their feedback and in the context, and also useful to ask your supervisor. And particularly if English is not your first language, practice speaking English as often as possible, including the use of medical terms that you should try and convey in an easy and understandable manner, avoiding confusing specialist language. There are practices, okay, sample questions 2 and 4 on the MRCP website. These are very, very similar to those encountered in the examination and excellent source of practice material. So make sure you ask, okay, your senior colleagues to watch you taking a history or communicating with a patient or a surrogate. Okay, these are the 2 key areas, because in the new format, which I will highlight in a few minutes time, you can see how communication skill also forms quite a important part of the assessment. The skill D, poor differential diagnosis, failure to consider the right diagnosis, and obviously being rather regurgitating what is there in a textbook rather than a list of diagnosis relevant to the patient you have just seen. Okay, and arguing about it. I don't think this is a PE for the chest pain because for various reasons and so forth. Okay, in that context. So practicing discussing differential diagnosis for all the patients you see. And again, education supervisor, senior colleague is quite important, and obviously agreed to be observed examining patients and formulating differential diagnosis. Clinical judgment is also a linked skill. If you fail to identify the physical signs, okay, you fail to consider the differential correct diagnosis, you'll be marked down on clinical judgment. You must be able to suggest appropriate investigation and discuss a sensible management plan, right? So differential diagnosis, investigation, management plan. Okay, 3 key things. Good management of the wrong condition obviously is not going to give you much marks at all. So if you have failed that, not familiar with the correct management plan, inappropriate investigation, failing to correct the clinical signs, or reaching the correct diagnosis, and obviously therefore suggesting an incorrect management. Feedback, again, asking other colleagues to look at and observe what you're doing, okay, in the context as broad as possible of medical patients as possible. discussion, differential diagnosis, appropriate investigation and management. And obviously, if you identify what are your gaps, is to review those areas, okay, that you actually fill up as much as you can. The ability to identify a patient's main concern is really important to ensure a satisfactory consultation. So 2, 4, and 5 station have specific questions for the patient and surrogate to ask for the candidate. You must demonstrate your ask, okay, the patient surrogate if they have any question, and answer them correctly and sympathetically. And that you ensure that the patient have understood your explanation and discussion. Okay, so the F is you have not passed, is you have not explored the patient concern, not listening, you're talking over the patient or relative, you're not checking what the patient or relative have understood what you have discussed, you appeared unconcerned and failing to build a rapport with the patient, which is actually quite an important part of that assessment, and you're running out of time, okay, to actually ask if they have a question to answer them. So again, practicing, review where things that may have gone wrong and during each scenario and discuss it, okay? And when you're interacting with patients, focus on identifying the concerns and ask for the feedback. And again, if English is not your first language, use every opportunity to practice potential scenario. Use a timer, okay? Managing welfare, yeah, trinity, sensitivity. Examiners have felt that you do not treat the patient and have failed to ensure their safety and comfort. You have caused the patient emotional, physical discomfort. You may have failed to make decisions that have jeopardized the patient's safety. Okay, so reflect and think about what your relatives like to be examined and cared for. And that's always, I actually depart a lot of the context. What would you like your relative to be told and be looked after? Okay, in that context. Would you like that doctor to look after that particular relative of yours? Okay. So yes, a lot of resources that you can practice, okay, in the context, videos, how to prepare, and there are preparation courses. Okay, so now I've just got about 4 or 5 slides, okay, and I'm on time. I'm so pleased, okay, in the context about PACES 23. This is for the current exam coming in March and the one in summer, July diet, the first and second diet, you will be still the old format. PACES 23 will start to happen in the final format of the year. This has been a planned introduction to changes to PACES 2020. PACES 2020 didn't happen because of the pandemic. Okay, we were preparing it since 2019, and there were pilots, okay, involving candidates to do that, okay, in the context. It was postponed due to the pandemic, so the examination will still test the same clinical skills. So what I've said about what's that 7 skills to still apply, okay, and there will still be 5 stations. The changes are a product of the 12 months review of the examination to ensure it remains fair, relevant, and fit for purpose. And indeed, there is a website, okay, to show you furthermore information. What is being improved? Session 2, the history taking. In actual fact, the history taking is actually a giveaway. Okay, if you are really good, okay, it's a giveaway, okay, in the context, unless you are really a poor doctor, okay, you don't see patients, you're very few patients would fail station 2, okay, in the context. So the history taking and isolation is being replaced to combine it with a focus examination. Station 4, obviously the 20 minutes for a single communication and ethics encounter was felt to be a bit too long, and 5-minute examiner adds little value to the candidate's overall assessment. Station 5, everyone gets palpitation, or the candidates get palpitation. The examiner gets palpitation as well, because we have to listen and see what you're doing, ticking boxes of what you have done or what you have not done, testing all 7 skills in the exam. It's very like real life, but very, very under pressure for 10 minutes, okay? And that's not realistic, because that's not what you do in the acute medical unit, right? You take more time to actually see those patients. So what is being introduced? 2 10-minute communication encounters integrated, okay, into one of the physical stations. No question and answer session, and the encounter is being judged on observation of the interaction. So those new med students will realize that, yeah, some of the stage 4 station, mostly, we don't ask questions, we just listen to you, okay? We have examiners, we have to keep awake, okay, to see whether the points that you're asking, we tick, 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 okay, hey, they didn't ask this, okay, in the context. Clinical consultation, 20 minutes clinical consultation, assessing candidates across all 7 skills. So this is something that international graduates have to take grips on, because you don't know these are the areas that you are not so good. Okay, so you need to practice and actually develop and cultivate, okay, and upskill those areas. Candidates will have 15 minutes to take a structured history, examine the patient, explain the likely diagnosis and management, and address any questions or concern with rest. And then therefore they have a 5-minute question and answer section with the examiner. So the examiners have got 5 minutes, okay. And the candidate is supposed to spend that 15 minutes doing the structured history, examining the patient focus, explain the likely diagnosis management, and address any concerns and question the patient has. Okay, hey, very like Mosler, right? Okay, in the context in terms of a new med examination setting. Okay, and the 5 minutes instead of the 7 minutes in the final year. Okay, they will get 5 minutes of examination. So the encounter sequencing across the carousel, the new carousel will alter the sequencing of the encounters through the carousel. Physical examination encounters will align with communication encounters, will increase the whole number of judgments. That's why we want more examiners to take part in the assessment. And examiners will now make judgment on all 7 skills instead of only 2 in the current format. Okay, it's station 5 in the current format that all 7 skills are being examined, but now more examiners. Okay, so this is the carousel. Okay, in context that you can see, station 1, you still got the respiratory station, but 10 minutes of communication where there is no Q&A. There's no questioning by the examiner. Session 2, yes, that's the 15 minutes clinical communication with 5 minutes with the examiner. And the 15 minutes that you have to do, focus history, examination, addressing the patient's concern, and explaining the aspects of your differential diagnosis to your patient. Session 3, yes, that's a physical station that has got cardiovascular and neurology. Okay, 10 minutes, 10 minutes. So that's not been changed because that physical skill examination is very important. Station 4, communication skill comes in again, but again, this one has got no Q&A. Okay, and abdomen 10 minutes, and station 5, another clinical communication. So there are 2 clinical communication, inverted comma, very much like our new med Mosler setting. Okay, in the context that you have got the 15 minutes of focus history, examination, diagnosis, explaining what you think is likely to the patient and addressing the patient concern, okay, in that context. Right, so this is the marking, don't worry, okay, this is very crowded, just to show you why the system is changed. So now you get all 2, 4, 6, 8, 10 examiner in one carousel, right? 2 examiners in each station. All 10 examiners have now got the opportunity to assess all the 7 skills, whereas previously it was only 2 examiners in station 1 to make it much a fairer exam. Okay, so the pilot study that was done in 2019 before the pandemic strike, where we had a number of your counterparts in UK that went through the scenario to see how it goes. The response has been really, really positive. They think that it's a much better exam in that context. The calibration will still remain unchanged. So specific criteria that we use to judge and whether the candidate is met. And again, ST3 level, okay, that's level 3, okay, in the new internal medicine curriculum. Okay, and this is just to remind you again, okay, in that context, and I would actually leave that other slide up, okay, in the context that I know, the long waiting list you guys have got, the anxieties, like 5, 6 times, no, they're not giving me a place. I think they're trying very hard to clear the backlog, okay? there's a huge waiting list. Okay, Singapore has managed to clear a lot of the backlog. Hong Kong has managed to clear backlog, but they don't have such a big pool as what we have. Okay, we've got a big pool of candidates all wanting to sit at MRCP, already in a position to sit for the MRCP, but no places. Okay, but now Malaysia has got the largest number of examining centers in the world internationally. Okay, to try to cope up with that backlog. Okay, so thank you very much, Shira and Chris. Okay, if Chris is still online, thank you.